Welcome to RP CME webinar. This is the 12th and last webinar. We promised to give 12 CME webinars this year, and we are finishing up with a bang with one of the renowned speakers, Dr. Shailendra Basin today. And this year we have given several hours of CME through RP. We gave 12 with these webinars and 10 in the Japan and South Korea trip, and 10 in collaboration with eMed Ed, and then 2 hours with Global Health Summit, which was held in New Delhi in October of 2024. Then we have this Arctic trip coming up, and we are giving 8 more hours of CME. And in the convention, which is next month, July 24th to 27th, we'll be giving 10 more hours of CME. So we're giving a total of 50 hours of CME this year, which is a good number. I don't think we ever gave this much of CME in the history of Hoppy, so we are proud and excited about that. And I want to welcome Dr. Amit Goel to introduce our speaker and our moderator tonight. Dr. Amit Goel is the chair of CME Committee of Hoppy. So Dr. Amit Goel.
Thank you, Satish. And again, it gives a great pleasure to introduce our speaker and moderator for our grand finale. It was sort of a very nice and I would say a very interesting journey all along last year, organizing all these webinars to sort of go out in the realm of world of internal medicine and general medicine in general. And thanks to Satish for giving that opportunity to me. And I was able to, it's just like a kid looking in a candy store, what's new out there. So in the quest of all that over the last 1 year, thank you for all the support that API has given and participation. So it gives a great pleasure to introduce our speaker for today, Dr. Shailendra Basin. He did his medical education in All India Institute of Medical Sciences, New Delhi, India, followed by residency at Northwestern and then fellowship at UCLA. And he was a faculty there at UCLA for many years before moving to Brigham Hospital, where now he's a professor of medicine of Harvard Medical School, director of research program in men's health, aging and metabolism, and director of Boston Claude T. Pepper Older Americans Independent Center at Brigham and Women's Hospital in Boston. When I first approached to him, my intention was to ask him to tell us how to decode the aging process, because that's his area of interest. And as I spoke to him, I quickly realized that a lot of this research is not at the level of where we can just take a pill and get an answer to anti-aging problems. So then we moved on to a different, very important topic, which is the treatment of hypogonadism and where we are in that process. And I'll let Dr. Gaitonde talk a little bit about that topic as Dr. Basin presents. And then our moderator for today is Dr. Krishna Gaitonde. He's a urologist who worked with the University of Cincinnati and very renowned internationally. I think there is no part of the world where we talk about urology and he's not known in those chapters out there. He's also an entrepreneur. He's innovator for BitCure Incorporation and co-founder board of directors, urologist with expertise in prostate cancer, targeted diagnostics and focal therapy, based out of Cincinnati, Ohio. So, and he's kind enough to do the moderation while he's on vacation on the West Coast. So thank you, Krish, for doing that, and welcome, Dr. Basin. And I'll let Dr. Gaitonde just talk briefly about the topic that we are talking about today before Dr. Basin takes over. Thank you.
So yeah, thank you, Amit, and Satish for putting this. I think this has been a great series. I've attended several of these. And when Amit called and told me about this topic and the speaker, I said, what a fantastic way to do the grand finale. Dr. Basin obviously is a very accomplished, endocrinologist. And again, it's as I was telling him earlier, as a urologist, I see men with hypogonadism, and often I need expertise from people like him, and it's not easy to find people with his expertise and experience. So I think we are fortunate to have him give us this talk. Again, today, hypogonadism, or a lot of which is testosterone replacement and other things which he'll talk about, is in the realm of primary care. So I think this is a very relevant topic to know exactly, what are the options out there. At what point do you send the patient to somebody with Dr. Bhasin's expertise? And again, I think he's has been involved with a lot of scientific research. He's again the editor-in-chief of, I believe, the Essentials of Men's Health, right? That's a textbook, which is, again, part of his academic and scientific work that he has done. So I look forward to hearing from him. And thank you again, Dr. Bhasin, for accepting the invitation on behalf of API, and love to hear your thoughts and also the questions from the audience, I'm sure, which they would love to get your thoughts on. So thank you.
Thank you, Dr. Gitonde, and thank you, Dr. Govil, for inviting me to give this talk on a topic that I've thought about for most of my grown-up years. Here are my conflicts. In particular, I'm not speaking on behalf of the American Board of Internal Medicine or the Endocrine Society. So testosterone was one of the first hormones to be chemically synthesized and approved in the late 1930s. And testosterone preparations have been in clinical use now for almost 90 years. So why is testosterone treatment so controversial? Prior to the advent of radioimmunoassays for the measurement of testosterone concentrations, most men who were diagnosed with hypogonadism had severe testosterone deficiency. In these men with severe testosterone deficiency, the signs and symptoms of testosterone deficiency were clinically readily apparent: delayed or absent puberty, absence of secondary sex characteristics, marked loss of sexual function, and changes in body habitus. With testosterone treatment of these severely hypogonadal men, there also was obvious treatment effect: induction of secondary sex characteristics, marked improvement in sexual function, as well as changes in body habitus. So there was no controversy about the benefits or risks of testosterone treatment in these young men with severe hypogonadism. Around the turn of the century, with the introduction of Viagra and with the FDA approval of androgel, and direct-to-consumer marketing, the terms low T as well as erectile dysfunction, they became part of the dinner time lexicon. And this direct-to-consumer marketing of these products related to men's health enabled men, middle-aged and older men, as well as their partners, to more freely talk about their sexual and genitourinary problems and seek medical attention. So testosterone sales increased dramatically from around $18 to $20 million in the 1980s and early 1990s to about $100 million at the turn of the century, to over $3 billion by the year 2017. And they have continued to grow steadily, but at a lower rate since then as well. So it is in these middle-aged and older men who have mild testosterone deficiency and have symptoms that have substantial overlap with age-related symptoms, that the benefits and risks of testosterone treatment have been less clear, contributing to the controversy about testosterone safety and efficacy. So in this context, I'll talk about the complexities in the diagnosis of testosterone deficiency and what we can do in our clinical practice to reduce the diagnostic imprecision, particularly in the context of changing epidemiology and novel emerging syndromes of testosterone deficiency. I'll review the data from large randomized trials, particularly the T trials and the TRAVERSE cardiovascular safety trial to highlight the benefits as well as risks of testosterone replacement therapy. And we'll spend a little bit of time reviewing how to monitor testosterone treatment and how to manage erythrocytosis and PSA elevations during testosterone treatment. And then I'll conclude with some personal reflections and my own approach to managing patients with testosterone deficiency. So hypogonadism is a clinical syndrome, and it has two components to it: the failure of the testes to produce normal amounts of testosterone, which is testosterone deficiency syndrome, and then the inability of the testes to produce normal amount of spermatozoa, which presents with subfertility or infertility. So we'll talk today entirely about testosterone deficiency and won't touch upon infertility. So testosterone deficiency, because it's a clinical syndrome, the ascertainment is based both on the ascertainment of signs and symptoms, and then demonstration of consistently low testosterone levels measured using reliable assays. Conceptually, the diagnostic evaluation of men suspected of hypogonadism is very straightforward and very inexpensive, and it proceeds in 3 steps. The first step is ascertainment of signs and symptoms and excluding obvious systemic causes, such as chemotherapy, GnRH agonist, opioid use, prior anabolic steroid use. The second step then is to measure total testosterone concentrations and, if indicated, free testosterone concentrations. And if total testosterone concentrations are low, then testosterone deficiency should be confirmed by repeating the measurement of total testosterone, as well as obtaining a free testosterone concentration. Once you have confirmed that the person has testosterone deficiency, then the third step is to determine if the defect resides at the central level or at the testicular level. And this is best done by measuring LH and FSH concentrations. If LH and FSH concentrations are elevated in association with low testosterone levels, then obtaining a karyotype can help confirm the diagnosis of Klinefelter or exclude it. If LH and FSH levels are low or inappropriately normal in relation to low testosterone concentrations, then the defect resides at the hypothalamic pituitary site. And in these individuals, ruling out systemic illness, measuring prolactin, ferritin, iron, total iron binding capacity, evaluating other pituitary hormones, and in many patients obtaining an MRI scan to rule out a space-occupying lesion. So by process of exclusion, you'll be left with individuals in whom the cause of hypogonadotropic hypogonadism cannot be ascertained, and we lump them together as idiopathic hypogonadotropic hypogonadism, which is really a heterogeneous group of disorders and over 75 different mutations in genes associated with GnRH receptor or migration of GnRH neurons from the olfactory plasode during fetal life into their location into the preoptic region of the hypothalamus. In practice, there are numerous pitfalls that increase the diagnostic imprecision and contribute to the risk of inaccuracy. The signs and symptoms of testosterone deficiency tend to be nonspecific, and they have substantial overlap with complaints that middle-aged and older men may have even without testosterone deficiency. Sexual symptoms in epidemiologic studies have the strongest association with testosterone deficiency. So erectile dysfunction, low libido, and loss of morning erections are the most strongly associated with testosterone deficiency. Small testis, loss of body hair, tender gynecomastia also lend greater specificity to testosterone deficiency. Testosterone levels fluctuate a great deal in men over time, And some of this variation is due to biologic factors such as genetics, binding protein alterations, and secretory rhythms of testosterone. Testosterone levels are higher in the morning than in the evening. Testosterone is released in bursts every 90 to 120 minutes. Levels are higher towards the end of winter than towards the end of summer. And then methodologic factors such as assay precision and inaccuracy, especially in immunoassays, and differences in assay calibrators contribute to interlaboratory variation in testosterone measurement. Reference ranges are also poorly defined, and they continue to change with change in assays. And so even from the same lab over time, reference ranges change from year to year, depending on the type of reagents the laboratory is using. So how can you improve the diagnostic accuracy? Measuring testosterone using an accurate assay is really central to making an accurate diagnosis. Now, liquid chromatography, tandem mass spectrometry-based assays have become widely available from most of the commercial large labs. And these LC-MS assays provide high precision and accuracy, especially in low range that's prevalent in men with hypogonadism. The Centers for Disease Control's hormone standardization program for testosterone provides a benchmark, an accuracy-based benchmark, and total testosterone levels measured by LC-MS in CDC-certified labs are almost identical and are interchangeable. Also, as I'll show you, the reference ranges that we have published from using CDC-certified assay in my lab, those can be used interchangeably across labs that are certified by the CDC's host program. Also consider the effect of time of blood sampling, food, and illness. Testosterone levels should be preferably measured in the morning on 2 or more different days and in a fasting state, because testosterone levels decline after a meal, especially after a high carbohydrate meal. And one should avoid evaluating hypogonadism during an acute or subacute illness. As I mentioned, reference ranges vary across laboratory, and the reference ranges reported by laboratory are based on convenience sample of patients whose samples are sent to these labs. So they are biased by overrepresentation of people who have sexual symptoms, because you won't measure testosterone in a man unless the person reported some sexual symptoms or there were other reasons for testosterone deficiency. And these reference ranges vary substantially across labs, and even the same commercial lab changes their reference ranges on a yearly basis. So we, under the auspices of the Endocrine Society and by an NIH grant, we embarked on an effort to generate harmonized reference ranges using samples from over 4 epidemiologic studies across the United States and Northern Europe. And then using these harmonized values that were benchmarked to CDC's host program, we generated and published this range. And the 2.5th percentile value, which we deemed to be the lower limit of the normal range, was 263 nanogram per deciliter. And the upper bound, corresponding to the 97.5th percentile value, was 914 nanogram per deciliter. But these cut points should not be viewed as absolute, and I'll come back to that in a minute. In randomized controlled trials that have enrolled subjects with symptoms of hypogonadism and total testosterone concentrations less than 300 or less than 275 nanogram per deciliter have shown improvement in these symptoms and improvement in health outcomes with testosterone replacement therapy. So I think the lower limit resides somewhere around 263 to around 300 nanogram per deciliter. Let's consider the case of this 20-year-old man who requests evaluation for sexual dysfunction. He is well virilized. His testicular volume is normal at 20 milliliters. Serum testosterone level is 299 nanogram per deciliter in a laboratory that reports lower limit of normal at 300 nanogram per deciliter using a radioimmunoassay, which has a 15% coefficient of variation. So 15% is a reasonable coefficient of variation in any assay because CLIA allows laboratory, it gives that latitude to laboratories. So what is the true testosterone concentration in this patient? The main point in this rhetorical question is that if the true value were 300 nanogram per deciliter and the assay coefficient of variation or one standard deviation is 15%, then the measured value has 95% probability of being reported within 2 standard deviation of the true value. So between 210 nanogram per deciliter and 390 nanogram per deciliter. So if you drew a blood sample and sent it to the lab today, it could be reported as 210 nanogram per deciliter. And there's 95% probability that the next value will be between 210 and 390. It could be 390 nanogram per deciliter. So, and when clinicians here get a level of 210 and the next level is reported as 390, they get really very upset and they say, well, what kind of a lab are you running? And the fact is that a perfectly reasonable CLIA certified lab with an allowed coefficient of variation. So the cut points should not be used as Gauss given dictum. There's high level of imprecision around the cut point, and this range of uncertainty, the 2 standard deviation on either side of the true value. When the reported values within 2 standard deviation of the cut point, there's high level of uncertainty. So that in these individuals, diagnostic precision can be improved by multiple testosterone measurements over time, measuring free testosterone levels, using ancillary data, and using other biomarkers. So if multiple values are below the cut point, then you have higher level of confidence that the person's value is truly low. So insurance companies have become completely insane. They will approve testosterone prescription for a value of 299, but will deny it if the reported value is 301. It's so insane, and it drives me so, it makes me so upset. And I've had multiple conversations with people at insurance companies, and it's just, all of you as clinicians have dealt with insurance companies, but this practice of using cut points as absolute dictum is just absolutely insane. Let's consider the case of this 29-year-old man who's being evaluated for sexual dysfunction and infertility. He started shaving at age 15 and became sexually active at age 18. He appears well virilized, but has bilateral breast enlargement. His total testosterone level is 310, and his free testosterone level is 68 picogram per ml. So the lower limit of free testosterone is about 70 picogram per ml. So both values are very close to the cut point. Is he hypogonadal? The fact is you can't really tell, given what I just told you about the imprecision around the cut points. But if I told you that this person has LH and FSH values of 40 and 42 units per liter, you would say, of course, he's got primary testicular insufficiency. And if I told you that his testicular volume is 2 ml, you would say, of course, he's got Klinefelter syndrome, right? So ancillary data, measuring LH and FSH at testicular volume, tender gynecomastia of recent onset, loss of secondary sex characteristics. These are features that can lend higher level of specificity and reduce the risk of misclassification. So most circulating hormones, including testosterone, are bound to plasma proteins. So 98% of testosterone is bound and only about 2 to 4% is unbound or is free and is biologically active. Most of it is bound loosely to albumin, And the dogma is that it's bound with much higher affinity to sex hormone binding globulin, and a very small fraction to erosive mucoid and cortisol binding globulin. And the important clinical implication of the hormone binding is that when there are alterations in binding protein, particularly SHBG, then testosterone concentrations will be higher or lower depending on whether SHBG concentrations are high or low. And there are many, many conditions, particularly metabolic disorders such as obesity, type 2 diabetes, anabolic steroid use, hypothyroidism, that are associated with low SHBG. And so in people with alterations in SHBG, you can misdiagnose these individuals as being testosterone deficient when in fact their free testosterone level may be normal. So measurement of free testosterone can be particularly useful when the total testosterone concentrations are within 2 standard deviation of the cut point, or when you suspect a binding protein abnormality. So how do you measure, how do you determine free testosterone concentrations? There are 2 general approaches. One is directly measuring free testosterone, and there are many methods, but the gold standard is equilibrium dialysis. And most large commercial labs offer direct measurement by equilibrium dialysis. So you should specify measurement of free testosterone by equilibrium dialysis, because if you don't specify it, most hospital labs will measure it using tracer analog methods that are inexpensive, provide high throughput, but they are just useless. They are inaccurate, and their inaccuracy has been repeatedly shown. People also advocate that if equilibrium dialysis is not available, that you can estimate free testosterone using law of mass action equations from total testosterone, SHBG, and albumin concentrations. But as I'll show you, most of the conventional equations are based on assumptions that our work has shown are wrong. And we've published a novel algorithm based on ensemble allosteric model, which I'll share with you in a minute. And you can go to this website, truet.org, and you can download this application on your laptop. It's free. There's no encumbrance, and you can use it to estimate free testosterone from total testosterone and SHBG concentrations. And we've also published a standardized method for measuring free testosterone concentrations by equilibrium dialysis. And you can use these reference ranges. These are also published. The lower limit is 66 picogram per ml in men, and the upper bound is 309 picogram per ml. The law of mass action equations that have been widely used, such as the Vermeulen equation, are based upon a linear model. And this linear model is based on the simple idea that one molecule of testosterone binds one molecule of SHBG with a fixed KD, leading to testosterone SHBG complex. So you can solve this equation if you knew total testosterone and if you knew SHBG concentrations, and the KD of SHBG has been published as being 1 nanomolar. But our studies have shown that this linear model is inaccurate. It's based upon assumptions that are incorrect, that testosterone binding to SHBG, similarly estradiol binding to SHBG, is nonlinear. So if this model were correct, the red dots here for estradiols binding to SHBG should conform to the red dots here, but the actual observed data is shown in black dots. So the binding of estradiol as well as testosterone to SHBG is not linear. And similarly, using several different biophysical methods, we've shown that testosterone as well as estradiol binding to SHBG is nonlinear. And it's not just nonlinear, but the apparent KD of estradiols binding to SHBG as well as testosterone's binding to SHBG changes dynamically with varying concentrations of SHBG and estradiol. So how is that possible? For every hormone and binding protein, a KD has been published. And so how can you explain this dynamic change in KD? And I don't have time to go over this, but our studies, as well as initial cryo-electron microscopy studies, show that testosterone and estradiol bind to the first monomer with a certain binding affinity, depending on the concentration of the sex hormone and SHBG. It changes the conformation of both monomers. And when the second molecule binds to the second monomer, it binds with a different binding affinity. And this conformational heterogeneity results in the dynamic changes in KD. So I hope this video will work, and I'll show you. So the two monomers of SHBG is a dimer. It has two monomers with identical amino acid sequences, and they're shown here in red and blue, and estradiol is shown in purple. So you will see that the two monomers in this state are not identical. Their conformation, three-dimensional structure is different. And so at no point are the conformations of the two monomers similar. And so what is the significance of this allostery, this communication between the two monomers and the conformational heterogeneity with ligand binding? Our inference from the studies that we've done is that intermonomeric allostery in SHBG and in other binding proteins provides enormous versatility in ligand binding. So it also extends the binding range and provides enormous versatility in binding different ligands. So SHBG has enormous class specificity. It binds estradiol, and it binds thousands of phytoestrogens that we eat every day in our diet. It binds testosterone, and it binds hundreds of phytoandrogens that exist in nature. But it doesn't bind cortisol, doesn't bind progesterone. So it has enormous class specificity, but within class has enormous versatility. And this allostery and the conformational heterogeneity also extends the binding range. So estradiol, prior to puberty and in menopause, circulates in picogram concentrations, 2 or 3 picogram per ml. Then during in men and in follicular phase of the menstrual cycle, estradiol concentrations are 40 to 50 picogram per ml. And then just prior to ovulation, estradiol concentrations are 500 to 1,000 picogram per ml. And during pregnancy, the concentrations of estradiol are 20,000, 30,000 picogram per ml. Try dissolving that much in the test tube, and I have done it many times. You cannot dissolve estradiol at that concentration in an aqueous medium. So these binding proteins are nature's genius creations that extend the versatility of these binding proteins. The other implication is that testosterone and estradiol and DHT, they all interact because they bind to the same binding site. So no equation can accommodate all of these variations in hormone concentration. So direct measurement by equilibrium dialysis is ideal. But if you don't have access to equilibrium dialysis, our TrueT algorithm provides a closer approximation based upon the ensemble allostery model that I shared with you. So the epidemiology of hypogonadism and has changed very substantially over the last 15, 20 years. We did this analysis of men who were on testosterone treatment within the VA system, and we found that only 6% of men on testosterone had classical hypogonadism due to known diseases of the testes, pituitary, or the hypothalamus. 94% of men did not have an identifiable disease of the testis, pituitary, or the hypothalamus. And most of the men had chronic diseases. heart disease, cancer. Opioid use was the most frequent, most prevalent identifiable cause that accounted for 20% of testosterone prescriptions within the VA system. So chronic medicinal opioid use, prescription opioid use, has emerged as one of the most common cause of severe testosterone deficiency. And in men's health clinics, anabolic steroid withdrawal hypogonadism has emerged as an important and frequent cause. But a vast majority of middle-aged and older men who meet the criteria for the diagnosis of hypogonadism have a multitude of chronic diseases, obesity, heart disease, diabetes. So as BMI increases, SHBG levels go down. And so total testosterone levels are negatively associated with BMI as well as with SHBG. But men who have moderate or severe adiposity, they may also have low free testosterone concentration and may have true hypogonadism due to multitude of reasons, including systemic as well as hypothalamic inflammation, increased leptin, increased estradiol, which may feed back to suppress LH and FSH, and potentially other mechanisms. And this slide using multimodal MRI from a Swiss script shows inflammation in the pituitary and in the stalk in this person with obesity who had true hypogonadism. So one can improve the diagnostic accuracy by weighing the specificity of symptoms and exam findings using accurate assays, particularly LC-MS assays, measuring free testosterone by a reliable equilibrium dialysis method. And one should avoid making a diagnosis of testosterone deficiency based on a single testosterone level or only on the basis of low testosterone. And ancillary data such as testicular volume, LH-FSH levels can reduce the risk of misclassification. So prior to the publication of the T trials and Traverse trial, there were very few randomized trials that were adequately powered for efficacy as well as for safety outcomes. Most studies included men with low or low normal testosterone levels, and many of the studies did not require symptoms of hypogonadism. The doses of testosterone that were used in these studies were variable. Treatment durations varied from 3 to 6 months, and very little data was available on heart clinical outcomes, including correction of hypogonadal symptoms, fractures, progression from pre-diabetes to diabetes, correction of anemia, and depressive symptoms. And none of the studies were powered for major adverse cardiovascular events or prostate safety events. So the whole field was, suffered from this uncertainty about the efficacy as well as safety of testosterone treatment, leading to enormous controversy. So fortunately, over the last 5-6 years, data from both the T trials and the Traverse trial have been published, and these were two of the largest randomized controlled trials. And I'll share with you data from these two studies. The testosterone trials were designed as 3 linked efficacy trials that focused on sexual function, physical function, and vitality or fatigue, and enrolled 780 men, 65 years of age or older, with an average of 2 fasting testosterone levels between 100 and 275 nanogram per deciliter by LC-MS, with 1 or more symptoms, and the intervention duration was 1 year. Traverse trial was designed primarily as a cardiovascular safety trial, but it also included 6 sub-studies to look at several efficacy endpoints because of its long duration and large sample. It enrolled 5,200 men, 45 to 80 years, with 1 or more hypogonadal symptoms, plus pre-existing or 3 or more coronary artery disease risk factors. So the subjects had to have either prior coronary artery disease or 3 or more risk factors, and 2 fasting testosterone between 100 and 300. And the intervention duration was up to 5 years. So what have we learned from these and other studies? Testosterone, the strong evidence that testosterone improves overall sexual activity, sexual desire, and it corrects symptoms of hypogonadism. The effects on erectile function have been small and inconsistent across studies. In the T trials, we found small improvements in erectile function domain of IIEF, but in TRAVERSE, where there was high prevalence of diabetes, heart disease, and cardiovascular risk factors for ED, the erectile function scores did not improve with testosterone treatment. Testosterone does not improve ejaculatory function in men with ejaculatory disorder. And it didn't, in TEAMS trial, it did not improve sexual symptoms in men who had low normal testosterone levels and no sexual symptoms. 50% of men in TRAVERSE reported depressive symptoms. In men who had significant depressive symptoms, and in all randomized men, testosterone significantly improved mood and energy more than placebo. However, testosterone did not improve depressive symptoms in men who had clinical major depression. So testosterone should not be used as a treatment for major depression. Testosterone treatment consistently increases lean body mass, reduces fat mass, it improves leg press strength, as well as chest press strength and muscle power, improves performance in stair climbing and in walking speed, and it improves aerobic capacity. 15% of men with testosterone deficiency have mild normocytic anemia. 15% of men in T trials and TRAVERSE trial had anemia at baseline. And in both studies, testosterone treatment was associated with greater proportion of men treated with testosterone correcting their anemia than the proportion of men in the placebo arm. Also, testosterone treatment reduced the incidence of anemia in men who were not anemic at baseline. Testosterone treatment did not reduce progression from prediabetes to diabetes compared to placebo. Testosterone also did not improve hemoglobin A1C or fasting glucose, and the incidence of glycemic remission was similar between testosterone and placebo arms. Testosterone improves volumetric as well as areal bone mineral density in both the hip and the spine, and it also improves bone quality and improves bone strength. Improvement in volumetric and estimated bone strength were greater in the trabecular than in the peripheral bone. So what about the cardiovascular risks associated with testosterone treatment? In 2010, an NIA-funded randomized controlled trial in older men with mobility limitation, of which I was the principal investigator, was stopped early by its Data and Safety Monitoring Board due to significantly higher rates of adverse cardiovascular events in the testosterone group. But the trial was relatively small, the number of events was small, and the MACE events were not adjudicated. And no randomized clinical trials had been large enough or long enough to determine whether testosterone increases the risk of MACE. So this led to enormous amount of controversy. So FDA then convened an expert panel which reviewed the available data at the time and issued a report in 2013 that the data were inconclusive to determine whether testosterone increases cardiovascular events. And FDA required the manufacturers of testosterone products to conduct a well-designed clinical trial to evaluate cardiovascular safety of testosterone. So as a result of this, the TRAVERSE trial was designed and implemented, and I'll show you data from the TRAVERSE cardiovascular safety trial. In the meanwhile, we did a 3-year intervention study called the TEAM trial. So in this study, we randomized middle-aged and older men with low or low normal testosterone levels to testosterone or placebo treatment for 3 years. And we measured atherosclerosis progression using common carotid artery intima-media thickness, as well as coronary artery calcium by MDCT. And you can see that the rate of progression of atherosclerotic lesions measured by either of the two methods did not differ between testosterone and the placebo arm. In the T trials, we did coronary MR angiography, and we found that testosterone treatment was associated with a greater increase in soft, non-calcified plaque than placebo. But there was some baseline imbalance between the two groups in terms of the plaque volume. So this issue remains somewhat concerning and inconclusive. So TRAVERSE trial was designed to determine the effect of testosterone treatment on major adverse cardiovascular events among middle-aged and older men with hypogonadism with pre-existing or at high risk of coronary artery disease. So 5,200 men, 45 to 80 years, were randomized in a 1-to-1 ratio, stratified by pre-existing cardiovascular disease or CVD risk factors to receive either testosterone gel or placebo gel for up to 5 years. And the primary endpoint was a composite of major adverse cardiovascular events, non-fatal MI, non-fatal stroke, or death due to cardiovascular causes. So as you can see, the cumulative incidence of MACE was similar between the placebo and the testosterone group. And the cumulative incidence was about 7% in the testosterone group and 72% in the placebo group. Amongst adjudicated tertiary cardiovascular safety endpoints, testosterone treatment was associated with higher incidence of venous thromboembolic events than placebo, and among investigator-reported adverse events which were not adjudicated. The incidences of atrial fibrillation and acute kidney injury were higher in the testosterone arm than in the placebo arm. Testosterone significantly increased red cell counts, total leukocyte count, neutrophil, and monocyte count, and increases in neutrophil and monocyte count, but not hematocrit, were associated with increased venous thromboembolic events. Because of the careful selection of people and exclusion of people at high risk of prostate cancer, the incidences of high-grade cancer or any adjudicated prostate cancer were very low and similar in the two treatment arms. The incidences of acute urinary retention, invasive procedures for BPH, prostate biopsy, and non-pharmacologic treatment for BPH were also similar between the two treatment arms. The lower urinary tract symptoms measured using International Prostate Symptom Score were similar in the two treatment groups, and the changes from baseline in the IPSS scores did not differ between the two arms. One of the most surprising findings from the TRAVERSE trial was that, contrary to our expectation and contrary to our hypothesis, testosterone treatment was associated with higher, not lower, higher incidence of all clinical bone fractures than the placebo arm. Initially, when we saw the data, we thought the statisticians made a mistake, that they had reversed the treatment groups. But this finding has remained very puzzling. And the trivial explanation is that middle-aged and older men at risk for fractures became more physically active after starting testosterone treatment and had a great number of falls and fractures. And some credence to this hypothesis is provided by the observation that the two fracture rates started to diverge very early on, within months. in the two treatment arms, which would not be expected if testosterone were affecting the bone strength or bone architecture. So there's strong evidence that testosterone improves overall sexual activity, sexual desire in men with low libido, relieves hypogonadal symptoms, improves mood, energy level, corrects unexplained anemia, prevents development of anemia, increases skeletal muscle mass, muscle strength and power, reduces whole body and abdominal fat, and improves walking ability and bone density. And it does not increase the incidence of MACE, and the prostate events were low and similar in the two treatment arms. The rates of erythrocytosis were also low because of the careful monitoring of testosterone levels in both the T trials and the TRAVERSE trial. But surprisingly, there was testosterone treatment increased the risk of venous thromboembolic events and bone fractures. So I want to spend a couple of minutes talking about how to manage erythrocytosis during testosterone treatment and what to do about PSA elevation. And these are very vexing problems in clinical practice. So the critical testosterone will predictably increase hemoglobin and hematocrit. And the question is, at what level of hematocrit should you get concerned? As hematocrit increases, plasma viscosity increases, and it starts to increase exponentially once the hematocrit rises above 54, 55%. So as hematocrit rises, the blood flow also increases, leading to increase in oxygen delivery to the tissue until the hematocrit reaches between 50 to 60%, and at which point the net oxygen delivery to the tissue and the blood flow starts to decrease. So that's why the Endocrine Society's expert panel, of which I was the chair, recommended that if the hematocrit increases above 54%, one should withhold testosterone treatment, that hematocrit falls below 50%, and then restart at a lower level. So testosterone increases PSA, and increase in PSA can trigger prostate biopsies, leading to increased risk of detection of subclinical prostate cancers, because many middle-aged and older men will have subclinical cancers. So the question is, what level of PSA elevation should lead to a urological consultation? So first thing is, any PSA elevation greater than 1.4 nanogram per ml within 12 months of initiating treatment, or any absolute PSA greater than 4 nanogram per ml should be confirmed by repeating the PSA value. In both studies, we found that half of the men whose initial values increased by more than 1.4 nanogram per ml or were higher than 4 at the initial testing, when we repeated, those values had come back to normal. And another 50%, when they were referred to their urologists and urologists repeated the PSA, those values were normal. So the main point is, never take an action on a single PSA. But if the 95% confidence intervals of PSA variation between two samples drawn 3 to 6 months apart is 1.4 nanogram per ml. So that's why PSA elevations above 1.4 nanogram per ml are unlikely to be related to benign causes. So how should we then treat men who present with sexual symptoms and have low testosterone levels? Testosterone deficiency is not a fatal condition as far as we can tell. So the decision to treat men with hypogonadism should balance the potential for benefits in individual patient and also the risk in the context of the individual patient. And it should consider the imprecision in the diagnosis, especially when testosterone levels are within 2 standard deviation of the cut point. It should weigh the burden of symptoms and the severity of testosterone deficiency, and weigh these potential benefits against the potential adverse effects, and also the burden and the risks of monitoring, and the comorbid conditions that may increase the risk of adverse events like a previous history of prostate cancer, and the feasibility of alternate strategies like weight loss with GLP-1s, glycemic control, use of phosphodiesterase inhibitors in men presenting with erectile dysfunction. And then, of course, physicians and clinicians may weigh the potential benefits as well as risks differently, and consideration of clinician as well as patient values is important in patient satisfaction. So I want to thank you for your attention late in the day, and also acknowledge my debt to the many collaborators in multiple studies that generated the data for which I've taken credit tonight. So thank you.
Thank you, Dr. Bhasin, and I'll let Dr. Gaitonde take over from here. Thank you. Mahesh, you're on a mute right now.
Oh, I said we've got about 10 minutes for questions, 5 to 10
Yep,
minutes.
yep,
I think,
yep.
yeah, okay.
Yep.
Yeah, so thank you, Dr. Bhasin. That was excellent. And, you've tried to simplify a topic which is actually, simple on the face, but fairly complex when you start digging into it. So I thank you for doing that. There are some interesting questions. Let me, share them from the group. There is, I think that's Dr. Shukla. His question was, do you routinely check inflammatory markers in a case of hypogonadism? Any correlation?
I generally do not evaluate for inflammation markers. So depending on the associated conditions, in subsets of people with obesity or heart disease, inflammation markers like CRP may be increased, but they don't weigh in on our diagnostic criteria or in treatment decisions. So I don't measure them in clinical setting. We are looking at other biomarkers which we may use in increasing the diagnostic accuracy, especially around the cut point.
Thank you for that. So there is one more question from Dr. Notaki, and it says, I think you touched on polycythemia. So the question was that empirically, we do phlebotomy to keep hematocrit below 60%. Do you think there is any role for preventive phlebotomy?
Yes. So, we don't know the level at which the risk of erythrocytosis in terms of cerebrovascular accidents or cardiovascular events is increased. It's somewhere between 50 to 60, possibly we set the guidance at about 54%. But in individuals with pre-existing atherosclerotic disease, such as people on hemodialysis, when you give EPO and raise hematocrit above 36%, the mortality rates are higher. So I think in people with pre-existing atherosclerotic disease, the level of hematocrit at which the risk of cardiovascular events may increase may be lower, but we don't know it. And, in some individuals, a small fraction of individuals, they'll develop erythrocytosis at relatively low doses of testosterone. I've seen a few of these patients, and my speculation is these individuals likely have some mutations in the hypoxia sensing mechanisms. And there I've used periodic phlebotomy as a therapeutic strategy to keep their hematocrit in safe range.
That makes sense. In my practice, often, like I said, we will try to hold off first and see if the hematocrit drops. But probably phlebotomy, like I said, might have a role in certain situations. So there's one more question from Dr. Bhandari, an interesting one about the fractures which you mentioned in people who are on testosterone in your study. And the question was the DEXA improved in patients who fractured while on testosterone? And is the improved bone density more brittle bone. So is that what is probably causing the fractures?
Unfortunately, in the Traverse, we didn't do bone density or quantitative CT scans. And so clinical fractures were adjudicated, but we don't have DEXA data. In T trials, we did both volumetric bone density as well as DEXA, and we found improvements in both areal bone mineral density as well as volumetric bone density. And other studies, relatively very small open label studies of 8-10 subjects using MR have shown improvement in bone architecture with testosterone treatment. So it's very puzzling. We had hypothesized that we would see a reduction in fracture. So we still don't know why we observed this paradoxical increase in bone fractures.
So one more interesting clinical question, and I'll add to that because that's what I was going to ask you, from Dr. Gussain, saying, are there normal values for T for each decade? And how do you make relevant? So to that, my question, which is, I think, from the practical setting is, as you mentioned, testosterone definitely does help in patients with symptoms of hypogonadism, whether it's decreased, libido or fatigue, which a lot of these can cross over with other etiologies, right? Not necessarily testosterone. So how do you deal with men who a lot of us see in practice where the testosterone is low normal and they have symptoms? And I think one of the issues, of course, is dealing with insurance. But assume that, let's take the insurance out of the picture. You have a man who's as I would put it, in the lower quartile of normal. He's got lower quartile of normal, ranging from, let's say, 300 to 400, has symptoms. How do you deal with that situation? Because that's where you normally see a lot of men. And the question that some of them will ask is 400 my normal, or was I 800 before and now am I 400? So how do you know? And what is your target at that point? What are you trying to come to? So this is a clinical relevant questions, I think, which obviously probably will a lot of primary care physicians, even as urologists, that we face.
Yes. So it's a really important and valid question. And so I think the first part of the question was, are there age-adjusted reference ranges? And should we use age-adjusted reference ranges? And in that paper in JCEM, where we reported the reference ranges, harmonized reference ranges, there's a very large supplement which provides age-adjusted reference ranges for total testosterone. And we've published reference ranges that are age-adjusted also for free testosterone in a separate paper. The issue there is that, you can use a T-score approach where you use a healthy population, like we do for bone density, for instance, for defining osteoporosis. Or you can use Z-score where you use age-adjusted reference range. Now, for conditions or for analytes where there is tremendous age-related change, for instance, after menopause, the estradiol concentrations are very low, 2 or 3 picogram per ml. Now, if we were to use age-adjusted reference ranges for estradiol, then one would conclude that most menopausal women are not estrogen deficient, but they are estrogen deficient because they are showing symptoms of estrogen deficiency. So it's not appropriate to use these scores for estrogen. So many people have argued that T-score approach using reference ranges in 90 to 40 years. So the ranges of 263 to 914, they are based on the T-score approach. They're based on a healthy sample of young men, non-obese, 19 to 40 years. Now, having said that, in clinical trials, the patients were included if they had levels less than an average of 275 in the T trials, and less than 300 in the Traverse trial. And if they also had symptoms and values below this, 2 values below this cut point, then they showed improvement. So I think that suggests to me that the lower limit is around 300 or slightly below it. Now, the measurement variation should be considered when the values are very close to the cut point, because there's there's high risk of imprecision, as I described earlier. But then we need to have some cut point, but consider the imprecision of measurement. So I think as a policy, it's hard to make a recommendation to treat people whose levels are 400. But as clinicians, we tend to be more pragmatic. And I think when the levels are close to the cut point, one needs to consider these sources of variability.
Yeah, because I think that's where the whole, the kind of question comes, because often you see these patients, and as you know, testosterone replacement is being done widely everywhere, and it's a lot of direct-to-consumer marketing too, as you said, with a lot of these things. So in your practice, if you have somebody who, let's say, comes with that range, low range, and has decreased libido, and you can't find anything else, what do you do at that point? What is your strategy because if it came to me, I would send him to Dr. Basin. That's how I would get off my, I'm just joking, but that's a difficult patient. So how do you deal with that? We have 400, patient, you can't find any, it's idiopathic, and now, what do you tell the patient?
Yes, I think I understand the thrust of your question, that if the person's testosterone is above the cut point, and the question is how far above the cut point. I generally use a hum and haw approach, and do multiple measurements over a period of time, and it also gives a chance for patient to consider alternate strategies in the meanwhile. But it's a challenge, but it's hard. In the team trial, men whose levels were over 300 and who had mild symptoms or no symptoms, they did not show an improvement in their symptoms with testosterone replacement. So given that data, I'm hesitant to treat people whose values are above 300. But as clinicians, I hum and haw after 2 or 3 visits and multiple conversations, then make a decision.
No, that's true. I think, like I said, like you said, it's a difficult area, and probably leads to some amount of informed consent and some amount of what you think is based on clinical evidence and strong data. So I think I'll probably just one more question. I think we again is with the impact of testosterone replacement on fertility in young men. That's the other issue, right? But a lot of these men are, like you showed your the 2 examples, 20, 29-year-old. And in them, even if let's say the cutoff was below 300, the testosterone replacement, what is the alternative strategy? Just so that, to talk about it, like, clomiphene citrate or whatever, something, because if you replace testosterone, you're going to impact the fertility. So just wanted to know your thoughts and your strategy in treating low testosterone in a man who's interested in maintaining his fertility.
Right. So there are, a couple of strategies, and there's no particular hard and fast rule, but I generally won't start testosterone if the couple is considering to have a child in the next 1 or 2 years. In that case, I may treat them with HCG. My preference is generally treating them with HCG rather than clomiphene. And the question, I think implicit in your comments is, when do you use clomiphene? And clomiphene is a partial estrogen agonist, so it's a weak agonist. So in the presence of estradiol, it's acting as a partial antagonist. And so that's how it raises LH and FSH, by blocking the estrogen feedback upon the hypothalamus candide neurons. And so I worry, and the long-term safety of clomiphene has not been shown. And the other thing is testosterone's beneficial effects on sexual desire, mood, bone are mediated, and even on fat distribution and fat inflammation are mediated through its aromatization to estradiol. So I worry that partially blocking estrogen effect may have deleterious effect. Most of the studies have been short-term, 3 to 6 months. So it's hard to tell whether there is actual deleterious effect on bone. But many patients don't report the kind of improvement in libido that they observe with testosterone treatment. So I've generally not used clomiphene as much. I think we need a head-to-head trial of clomiphene and testosterone.
So the HCG, again, the follow-up, and then we'll end with this HCG, what you mentioned, is that something that, in the primary care practice setting they could use? And is that because, and what is the insurance coverage for that? Because I believe that can be a little bit of an issue, right? So if you can just address that one point, is that something that primary care physicians could use? What is just simply the dosage of it, and what are the insurance issues with trying to get it approved?
Yeah, so it requires pre-authorization and same kind of barriers that you see with testosterone, and the HCG availability varies, but there are a couple of different companies whose products are available, and so there are special fertility pharmacies which provide most of the insurance companies have special fertility outlets that provide HCG. So it's possible to get it, but the insurance companies, it's a little bit of a hassle getting the pre-authorization.
Okay. No, I think this was fantastic. I know, like I said, it's a very important topic, as it is. We all see men with these issues, whether it's in a primary care practice, whether it's in a urology practice like mine, or specialty endocrinology practice like yours. So I really appreciate you taking the time to share your expertise and enlighten us. And look forward on a personal level to now that I've got to know you, I know who to call if I have a patient who I have a question. Thank you for doing this, and I'll just hand it over to Amit and Satish to close the event. So
thank you, Krishan. Thank you, Amit.
Thank you, Dr. Bhasin, and thank you, Dr. Gaitonde. This was an enlightening session, and again, just a note that we look forward to seeing many of you all for the RP convention end of July, and so looking forward to that. And thanks for a lovely year that we had. Handing over to Dr. Katula. Thank you.
Thank you, Dr. Bhasin and Dr. Gaitonde for your excellent insights. And thank you, Amit, for the whole year. It's been really fun working with you, and we still have more to go, one more month. And as you said, we'd like to invite everybody to RP Annual Convention in Cincinnati from July 24th to 27th. And we'll have 10 hours of CMEs there, and entertainment, and several keynote speakers, including Nobel laureate Dr. Capecci, and American Medical Association President Dr. Bobby Mukamala, FSMB Chair Dr. George Thomas. We'll have many more dignitaries there, so please do come. Please register as soon as you can. With that, I'd like to present a little token of appreciation to Dr. Bhasin. So Vijay, could you please project that? The American Association of Physicians of Indian Origin recognizes Shailendra Bhasin, MBBS, for his outstanding contributions in the field of endocrinology and men's health, and welcomes him as a member of RP Distinguished Speakers Club. Satish Kathula and Amit Goel, June 18, 2025. Thank you, Dr. Bhasin, for enlightening us with your expertise and experience. Thank you. Thank you all for joining today.
Yeah, thank you.
Thank you. Thank you.
Thanks all.
Take care, folks. Thank you.
Thanks, everybody. Yeah.
Bye-bye.
Bye.